right shoulder up in front, flexion, wherever you can go. Okay, and back down. Let's see your left side. So, back down. Raise them both up at the same time and stop where they hurt or where there's limit. So she does have more on her left than her right. So perfect. And come back down. And go ahead and do that again. So I'm just looking at, and come back down, face the audience for me. What I'm looking at is when she comes up, where does it pull? Where do I see lines of tension? Some of this takes a while to observe and start to get a feel for things. But go ahead and raise them up again. And just looking at that quality of movement, this one keeps going, and this doesn't lift or elevate as well. Something maybe is adhered or tight in her right rib cage area. Okay? What I like to also do is feel, palpate, and go ahead and just relax and close your eyes. Find your feet and take a couple nice deep breaths. Move your feet hip width, please. What's her diaphragm moving like? How is her breath? Does one side feel like it's elevating more than the other? And so she does feel to me, and it doesn't always mean that the side that elevates more is the problem side, but she does feel like there's more upward movement in her right rib cage and lungs than on her left. In the Visceral Institute, they teach you to feel lines of tension in the body through the shoulders, from the arms, from the feet, from the head. So I'm going to feel into her head just to feel, as I go into her system, does she buckle anywhere? Is there a give? Is there a tug? Is there anything that I notice that's asymmetrical? So go ahead and just close your eyes for me. And you can watch her. I don't know if you can see any shifting or buckling, but as I come into her system, she kind of does a little shear almost at the diaphragm level. So I'm starting to use that sort of thought process that maybe she doesn't move well through her rib cage on this side. Her shoulder flexion's limited. There's something that's pulling in her system on this side. So go ahead and face that way again for me. So now how do I see if I apply support or change or input into the nervous system at the diaphragm, does her shoulder flexion change? If it gets better, I start to think, yes, definitely something inside is influencing shoulder mobility. If it does not, I go, okay, more musculoskeletal. I need to really look at the AC joint, the glenohumeral joint, the SC joint, the structure. So it's just starting to give me a direction of, do I go this way or do I go that way with my treatment choices? So go ahead and raise that arm up as high as you can for me again. You can do both. Yeah, that's fine. Was better than the first time. And so if I come in and just support, can you go any further? Does it change it? Did it change it at all?
A little bit.
Okay, come back down. Okay, so let me come into it and support it before she moves. So are you okay with me coming in?
Yeah.
So I'm just coming in and compressing at the diaphragm. So I don't know if you can fully see where I am. Relax your shoulder. Okay, and then raise it up again. Was that different that time?
Yeah.
Less pinching, change?
Not nearly as much hypermobility happening in the shoulder.
Okay, and back down. So a little bit of a change. So at least I know, and there's some that will go with truly high dysfunctional shoulders. You'll see them get to like 130, and you support the diaphragm, the rib cage, and they might go all the way up, and they look at you like, what did you just do? Hers is a little bit of change, so there's an influence. Okay, so I'm going to keep you for the next demonstration if you're okay with that. So that's looking at how input into the nervous system might influence range of motion. Okay, with your head down here. Okay. So go ahead and lie on your back for me. That was active motion. I like to feel passive motion as well. So go ahead and bring your arms to 90 because she at least has 90. And then just relax. And I'll take her back and feel and watch where does tension happen in her body. And this arm wants to keep going, and this one stops. And so then if I compress or influence it, it changes it. And that was easier for you guys to see probably, and easier for you to feel. Okay? So again, that's just that same idea of how might something in the thorax be influencing shoulder motion. That could be a direct mechanical tension. It could be input into the nervous system. Any one of those two pathways, quite often it's a little of both. The next test is testing manual muscle test for shoulder external rotation. Since shoulder external rotation is innervated so much off of C3, 4, and 5, it's a really nice test to clue into the influences of in here affecting stability of the shoulder. So I'm going to assess shoulder ER in this position. So go ahead and hold. Let me do this. More of you are on this side. Do it this way. Go ahead and hold. Don't let me move you. Okay? When she holds, go ahead. Hold on, move you. She starts to pull in, and her trunk kind of does this sideways shear at her rib cage. Hold. I'd still give her pretty close to a 5. Okay? Is there any pain with that?
I just feel it where I shouldn't feel it, but there's nothing in the shoulder.
Okay, hold. Can you guys see how much she buckles though? So I wouldn't give her a 5 because it's not clean. I might call it a 4 with the shear at the thorax. Hold this side. She's a lot more solid on this side. Her trunk stabilizes. She actually shears a little bit over there. So, and you can see the strain in her neck. So if I come back into that diaphragm rib cage area, I want to see first how much that helps this side. So her neck doesn't strain on this side now. Can you see that change? I actually had a camera. Can you feel that difference?
I do, yeah.
Okay. I'm not compressing massively and stabilizing. I just have my hand on her, and she gets stronger. Okay. This side, I'm going to test her and see how much better. But I have patients that will go from a 3+ to a 5 if I find the right structure. Now, going back up. Hold. If it's more liver fascia, that might be it. If it's more diaphragm, that might be it. I might have to come up to the lung pleura area, and that might be it. And that actually helps her more. She knows it. So what I'm saying is, if you come here and it looks faulty, they don't stabilize through the trunk and core and neck, and you see overfiring, and you've seen lines of tension go into somewhere, support it. See if it changes. And I'm not stabilizing. I'm lightly compressing and giving her brain different input for it to go, oh, the shoulder's okay. That's really coming off the phrenic nerve. And her neck doesn't have to strain as much. So let's try it on.
Pain there too, by the way.
And she gets pain there. Okay. So did you have bronchitis or pneumonia or valley fever, any of those?
Bronchitis.
So that potential of maybe some adhesions in that area, or maybe from a fall, or maybe from other things. So I'm sorry if my body's in the way on this side a little bit. I'll go here again. So if I have her go ahead and hold, and you see how her whole body shears. So let me go to that spot that was better for the other side. And that definitely takes away some of the shear. Okay? So this is someone that isn't coming to me for PT, but used for demonstration purposes, and even there were some changes. But some of your patients, I mean, they'll go from a 3+ to a 5. And so that has to let you start to think about, it's not just the shoulder that's the problem, that there's something within, maybe it's an intercostal, maybe it's a rib, maybe it's the lung pleura, maybe it's the diaphragm, but something else contributing to it, okay? If this cascade goes on long enough, guess who really starts to scream and have problems? You truly have mechanical breakdowns, because every time she goes to use her shoulder, she's shearing and having problems, so now she starts having neck pain, now she starts having shoulder impingement signs, maybe true mechanical dysfunction at the AC joint, SC joint, other things that started further back. So these are some things for you to play with